So I will cover aspects related to how Dr. Lamba has implemented CT protocol naming conventions to assign patients to protocols based upon clinical indications. And one of the things, I am not a clinician, and I picked up a lot of work from things that I've done with Dr. Smith-Feynman with the UC dose endeavor, the dose optimization and standardization endeavor, and I gave some of these talks at those meetings. So without further ado, let's go. See, the protocol guide that we've developed at UC Davis is a compendium of Excel documents for specific radiology division, for instance, abdominal, neuro, pediatric, cardiothoracic divisions within radiology. And each division has its own number of protocols. So when we look at a specific protocol, and we're going to use the body section as the body division as the representative example here, since Dr. Lamba is from the body section, we look at each major protocol that's entered in the left column of a row in an Excel spreadsheet. For example, what we would have in the left column would be a protocol name, abdominal pain, routine pain, and abdomen study. The indications for the study are described in the middle column with unique characteristics satisfying multiple indications, for instance, four-phase liver or widely accepted nomenclature such as a urogram. The third or rightmost column in this spreadsheet provides the information on the test to order. Each test has specific CT scanner parameters and exam-specific techniques dependent upon the CT manufacturer, the exam-specific techniques per CT scanner, and patient habitus and any other special instructions. Most all protocols at our institution use automatic exposure control, tube current modulation, and iterative reconstruction algorithms to maintain image quality at the lowest possible dose. Obviously, one of those optimization efforts that we try to do. Several examples of the protocol guide follow in subsequent slides, and then we'll get into more details as we move forward. So here's an example of an Excel spreadsheet that Dr. Lamba has developed with examples shown for the general abdomen and pelvis. Each protocol on the left column for trauma, abdominal pain, routine abdomen and pelvis, and metastatic study is in the left column. Each has clinical indications and instructions using general naming or widely accepted nomenclature, for example, non-specific abdominal pain or pancreatitis, acute cholecystitis, or other indications as shown in the middle column, and the test to order in the right column as shown in the right column there. So I'll show you several examples of how Dr. Lamba has implemented his specific protocoling and how he can match that to a specific patient. So continuing on, these are still the various different types of protocols, clinical indications, and tests to order. For these protocols and indications, the test to order is the CT abdomen and pelvis with contrast, except for the abdomen only exam. So if we take a look at all of the different tests to order, we see that they're all CT abdomen and pelvis for these specific types of protocols: abdomen only, abdomen and pelvis with positive PO contrast, small bowel obstruction, large bowel obstruction. And in the middle column, you see the different indications for these different types of protocols as shown. I'm not going to go into any details, specific details, just simply because I'm a little bit far removed from the details related to clinical implementation and acquisition, but I'm just providing you these spreadsheets that you see the really fairly high detail in terms of the protocols, the indications, and the test to order. Once we get to describe the test order later in the talk, we'll see that there's even more details there that help in providing the optimal study for a given clinical indication for a patient. Continuing on the list, other protocols for the abdomen continue in the first three rows of the spreadsheet. Then we move on to specific body organs, such as the liver, where it has a 4-phase protocol for indications of hepatocellular carcinoma, post-radiofrequency ablation, and transplant. For the pancreas, the pancreatic mass protocol has various indications as listed and the specific test to order, same as some of the other protocols. Specific instructions for CT technique parameters, contrast injection, and post-processing for the specific indications regarding the protocol and the test to order will be shown later. Now moving on, we're obviously going through all the different body protocols. We're moving to the kidney and bladder organs, where various protocols are shown for renal stone follow-up, which is a low dose protocol, renal mass, urogram, renal transplant. Indications for each protocol provide details and the associated test to order. Of note, the test to order for different indications might be the same, so we have the same test, but with potentially significant different acquisition technique parameters and post-processing requirements. Of note shown here is the difference between the evaluation of a renal stone and a follow-up low-dose renal stone protocol, which have large differences in dose, as everybody on this call should note and recognize. In some cases, such as pre-surgical evaluation of a potential kidney donor, specific orders for 3D post-processing, as shown in the right column, are important for the appropriate patient evaluation for the study. So we have this complete table, and we're just paging through the various different types of protocols in this case. More protocols and associated indications and test to order are shown here, with continuing GU, kidney and bladder organs, and adrenal and bowel evaluations. All of this material will be provided to Galina so that she can provide this in the notes of this particular proceedings. And I don't want to go into any major details, but you just see the protocol name, the indications for the specific types of organs. For instance, adrenal nodule, the characterization of an indeterminate adrenal nodule, suspected Crohn's disease, so on and so forth. Enterography, acute GI bleed, occult small bowel bleed. So we see that the tests to order are pretty much all CT abdomen with and without contrast, or in some cases without contrast, specific to the indications and the protocol name. Moving down the list, we have more protocols for bowel evaluations, followed by vascular CT angiography, CTA protocols that are shown here and on the next slide. I'm not going to go into any details. I think we will take a look at the various changes in the test to order for a specific indication and the specific protocol that the patient would be assigned to. In this particular slide, I wanted you to note the protocol names, associated indications, and the corresponding test to order. The current guide, this is a guide developed in 2014, just because that's all I had access to based upon my assignment given to me yesterday. But the current guide 2023, I guarantee you, has a lot more specific details demonstrating the fact that technology has changed. Our CT scanners that we have on site now have changed, and there are updates that are continuously occurring with changes in acquisition technology, the equipment that I previously mentioned, and post-processing capabilities. So this completes what I want to show you in terms of the protocoling guide. Now on to the details for the CT scanner acquisition protocols. So the CT scanner acquisition protocol tests are a way in which the acquisition protocols and the CT parameters are described in a SharePoint file that everybody that has password protected access to can access that on SharePoint. Here's an example of documents for body, chest, MSK, neuro, and pediatric applications of the protocols that are provided and accessible in the clinical environment so that you can get an up-to-date view of what the appropriate protocols are in this case. One of the things that we do is annual protocol review and verification of machine settings in a group meeting with technologists, radiologists, and medical physicists. So if we drill down now into the SharePoint protocol collection for the abdomen, this is what we described earlier in that Excel spreadsheet that described the protocol name, the indications, and the test to use. Each Excel file is represented by the protocol name as shown in this partial list. So we have abdomen, pelvis without IV contrast, so on and so forth, cystogram, four-phase liver, gastrography. Continuing on, we'll take a more in-depth view at the pain routine, abdomen, pelvis, which we use most frequently at our institution. And the associated information contained in this protocol list file. So beginning with the protocol list, we have the indications that were detailed in the previous information that I provided you at the beginning of the talk. In this particular case, this is the pain routine abdomen pelvis, the non-specific abdominal pain, appendicitis, diverticulitis. These are all the different types of indications listing for this particular protocol. So you see a large number of specific indications based upon the patient's issues that we have to deal with. If we now continue on at the top of the spreadsheet in another tab, we see the clinical indications are listed for using this particular protocol. So I've expanded it, and we have these specific applications that use either typical names and or descriptive methods of talking about the different indications, clinical indications. Moving on down that specific list in the spreadsheet are the acquisition instructions for contrast, including the method of injection, the equipment used, the type of contrast, injection volume, injection rate, and saline flush volume and rate. Patient setup is indicated also for this protocol. So we have this well-defined way in which we're going to acquire the images so that the applications will optimize the diagnostic capability and accuracy of the tests. Moving on down further, you can see the completeness by which Dr. Lamba has implemented these protocols. The localizer, the extent, scan range, KV and MA settings, window level, initial settings, machine-dependent kernel if necessary. For instance, in this case, the Siemens system has a kernel for the localizer, a specific kernel to implement different looks and changes in the way in which the images are processed. Estimated dose range for the exam, which is determined from the radiation dose monitoring database statistics that we maintain at UC Davis Health. So we can get typical minimum, average, and max values from our database, our radiation dose database, for this specific acquisition protocol. Then we move into another tab on the Excel spreadsheet in terms of the acquisition parameters for, in this particular case, Series 1, the portal venous series, the superior extent of the acquisition, the inferior extent, and whether or not we're using an axial or helical acquisition and any specific machine setup such as gantry tilt. The technical details in the slightly lower down in the spreadsheet show the machine specific detector configuration, gantry rotation time, table speed, which determines, of course, the pitch for helical acquisition, typical scan time for the intended body coverage, the beam collimation, scan field of view, display field of view, and acquisition KV. There's even more coming on the next slide, but this is shown for some of the scanners at UC Davis Health, including the General Electric and Siemens scanners as shown. We have a much wider fleet of scanners now. This again is 2014, 2015 version, and updated. We also have a high resolution Canon scanner, which really kind of changes the way in which we acquire and our technique factors are somewhat different because of the much smaller pixel and voxel dimensions in those scanners. The more recent documents have these systems listed in our up-to-date collection of protocol guides. And we moving down the acquisition parameters continuing. If we have automatic KV selection if offered by the manufacturer, whether dose modulation is implemented, machine and manufacturer specific details of iterative reconstruction, Acer for GE, Sapphire for Siemens, and some of the deep learning reconstruction methods on the newer scanners, the noise index values for GE and the reference effective MAS for Siemens as shown with adaptation curves. As shown with the red crosses, sometimes you'll see, well, what happens if you have to increase the noise or decrease the noise? There's some recommendations on how you would do that with, for instance, with the GE scanners and the noise index values that are listed in this, if in fact there is a need to do that. Post-processing details. What we see here is, these are included for each protocol regarding slice thickness reconstruction series for each type of scanner. Shown here are two axial reconstructions for 5 millimeter and 1.25 millimeter slice thicknesses, reconstruction interval, reconstruction filter or kernel, and their corresponding series descriptor. Also details for coronal and sagittal reformatting, thickness interval, kernel, and window level settings are shown for each type of scanner. They're the GE scanners and the Siemens scanners. And you can see all of the different parameters that are hopefully programmed in the scanner when the technology, well, in fact, they are, when the technologist selects the proper protocol. So now to conclude, we look at best practices and we have in-person meeting feedback that we do typically on an annual, sometimes a little bit longer than that, and sometimes a little bit shorter than that, particularly when we get new scanners in. The idea here is that we've described all that has been described regarding CT protocols and assigning patients based upon specific clinical indications is dynamic and changing. It is important to have these in-person meetings with key players, including CT technologists, radiologists, medical physicists, to streamline and control the process for creating and updating the CT protocols. The goals are to optimize protocols to reduce dose and maximize diagnostic value. Some examples include to use helical scanning, iterative reconstruction, and optimal KV selection. I'm sure these details have been discussed throughout this symposium, which I have not been attending. What we do is designate the lead CT technologist to oversee assignment of patients to specific protocols based upon radiologist recommendations and try to use intuitive protocol names to allow better standardization and assessment of dose over time, when that is one of the goals of optimizing this whole process. In order to maintain radiation dose at a low level without compromising image quality for a specific clinical evaluations, suggestions are shown in this slide to include reduced use of multi-phase CTs, such as avoiding non-contrast phase for chest CT, for suspected pulmonary embolism, and single phase for abdominal pain, trauma, pancreatitis, or appendicitis. I'm sure you've heard all of this, and I'm probably just regurgitating a lot of it. In multi-phase studies, reduce the dose for non-contrast and excretory phase scans, and reduce anatomic regions being scanned to minimize volume, such as not including the pelvis to assess a renal mass or urogram. And those things are implemented in our protocol descriptions. Use the lowest dose possible for low dose studies for lung cancer screening and renal stone evaluation. That's a probably pretty straightforward issue that we all tackle. A rule of thumb is that we use a lower dose if we want to see how low we can go by 10% increments until the noise becomes excessive relative to the necessary diagnostic image quality for the exam. I know that Ramit was really proud of being able to have really low doses, but sometimes they get too low and you have to back off and move back up. Other exams to consider a very low dose include hydrocephalus or pectus excavatum exams. So in summary, and to finalize, standardized CT protocol naming conventions, as shown, are very useful in assigning patients with specific clinical indications. CT scanner acquisition protocol coordination is essential. Optimizing CT scanner operations for the lowest possible dose without affecting diagnostic accuracy should be revisited periodically, which is typically on an annual basis, and determining, implementing, and maintaining protocols that require a team approach, including CT technologists, radiologists, and medical physicists. With that, I was reading a lot because I wasn't quite sure what to say, but I would like to thank you for your attention, and hopefully I've provided you some useful information for implementing and assigning how you assign patients to clinical protocols. And I am open for questions if there are any. And I'll stop sharing the slides at this point in time, I suppose.
Yeah, thanks, Dr. Seibert. That was great talk. I think the nuts and bolts that you presented are critical to any CT practice. So thanks for sharing all of those. We do have a question.
Okay.
From the chat. Do you profile your tube current modulation in your protocol book?
Tube current, do we profile it? No, we don't. We probably should. I think that's a really good thing to do. Let's see if I can exit here so we can see ourselves. How do I get out of the screen here? Stop share. There we go.
I assume by profile, I wonder maybe they mean like
do they mean
maybe of the dose over patient size, perhaps? Or
yeah,
just...
well, typically, with respect to tube current modulation, of course, that's going to what it will do is compensate for differences in patient habitus, of course, and the tube current modulation is one of those ways in which we can ensure, if in fact it's set up correctly, that we will get the appropriate dose that we need and optimized for the specific study. Do we profile it in the protocol book? That would be a better question for Ramit to answer. I don't have all those details at my fingertips anymore since I haven't revisited this specific talk for some time.
I did notice, and I liked how you guys had the doses in the expected doses in the booklet. That's a great idea.
Yeah,
I guess while we're waiting. Oh, go ahead. While we're waiting for another question, we'll take maybe a couple more questions. But I had a question. That is, so your protocol, I noticed like you started with the very specific like scanner radiology protocol, and then the kind of indications in the middle, and then on the right was kind of like the general like study description or orderable. Like, I don't know. A lot of times I think about it the other way, but that's an aside. Maybe I just don't think right. But I'm just curious. That left column, the protocols then at your institution, do those have a direct one-to-one mapping with a scanner protocol?
Yes, they do. Yeah.
Okay.
The only reason again, Dr. Lambo would be a much better person to be able to respond to this. And if it was about 6 years ago, I'd be able to respond to it a little bit better too. There is a one-to-one mapping for that. Okay. Yes.
Yeah, that's got to reduce a lot of error. I think we'll take 2 more questions quick, and then I'll do the last talk for this little segment here. So, someone's at Dr. Tipanis is asking, Tony, what's your take on the use of tracking cumulative effective dose while deciding on a future clinical imaging exam?
My take is if the exam is necessary and needed and justified, it doesn't matter what previous doses are. That's my stand. Although it is good to track that kind of information to see if there's potentially optimal or not optimal, but different types of procedures such as ultrasound or MRI that could provide a similar type of information. And of course, you wouldn't be delivering any radiation dose to those patients given the alternate exam. But
great. And
justification is the key. Yeah.
The last question. So if you had to pick one or maybe two like parameters to unify optimization among various CT manufacturers, what do you think would be the key parameter to get uniformity, say in image, let's see, image quality?
Key parameter. What would I say the key parameter would be? That would be across all the different manufacturers.
Yeah. Or what do you do in practice? Maybe if it's not optimal, but what do you guys try to do? This is a problem everyone has. How did you guys maybe tackle that at your shop?
Well, I'm not quite sure, Tim, of how to answer that one. I think again that Dr. Lambo would have a right off the top of his head example. I'll just push that back to you since you're now intimately knowledgeable about a lot of this stuff. What do you guys do at your institution?
I like to use dose when we first get the scanner. I try to like set the two scanners up to, if I've got a protocol that's humming on one vendor make and model, whether I get a new model from the same make or I get a new make and model from some other vendor,
Right.
We try to first just say, hey, if vendor A can do it at 50 milligray head or 35 milligray head, this vendor better be able to do it. And that's kind of where we start. And then the knob for adjusting that would be your image quality target, your noise index, your effective MAS, your SD parameter, etc. That's in practice. And then from there, there's like a plethora of things for reconstruction kernel, but I kind of start there.
Oh, I think that's a really reasonable thing. I'm glad I'm tuning back in a little bit, getting my brain back out of retirement. I think that's definitely the way to start. And then you have some unique scanners like the Canon precision scanner, which can have a much smaller voxel. It can go to 2048 by 2048. And the game and the protocol issues are changed dramatically for optimization.